Thank you very much. Good morning, Eric. Thank you again for your contribution.
Yeah.
We are, and you can go ahead.
All right. Good morning, everyone. Like Dr. Appel said, my name is Eric Tron, or a lot of you guys know me as Erki. I'm a reg at Stellenbosch currently, and I don't know if I should say it's a privilege, but it's a privilege this morning to be able to talk a bit about the urinary microbiome. And then my colleague, Dr. Chetty, will follow on the management side of recurrent urinary tract infections. So the urinary microbiome, it's a topic that's increasingly changing on how we think and how we approach urological health and disease. Just before we start, I think I should just disclaim, I'm not a microbiologist. I'm in urology, and so I'll take it from our side of perspective of things. So to cover today, I think just to understand what is the urinary microbiome, what's it composed of, how does it impact us, how do we test it, how do we assess for it, to discuss the clinical relevance in urological conditions and management and diagnosis, and then also to explore therapeutic, like I said, and diagnostic implications. So the first thing I think that's quite important to stress, and I think everyone knows it by now, but urine is not sterile. We used to be of the belief that urine is sterile up into the early 2000s, and then we kind of accepted that it's not really sterile. But the first real paradigm shift came with a paper that was published in 2012 by Wolf et al., which labeled the evidence of uncultivated bacteria in the adult female bladder. And that's kind of where we accepted that urine is not sterile and that there's a lot of bacteria in urine. So this starts with the previous slide, but the traditional view versus the new paradigm, as I said, we used to view urine as sterile. In the new paradigm, we accept that there's a distinct urinary microbiome or urine biome in healthy individuals. And this was enabled by enhanced quantitative urinary culture techniques and your 16S RNA or next generation sequencing of urine. So the two pictures on the slide, which I thought was quite interesting to put down, was on the left was from a large paper that was published in 2019, the Human Bacterial Repertoire of Urinary Tract, which has said a potential paradigm shift, and was published in the Journal of Microbiology. And up until that stage, and on that paper they published, was that there were 330 different bacteria that has been identified in the human urinary tract. And then if you look at the picture on the right-hand side, that was the very following year, 2020, on the Microgen database with the next generation sequencing. There we had already now identified more than 4,000 species. So I think we didn't think there was anything, then we realized there was something, and now we know there's a lot, and it's rapidly evolving in our way of detecting this. So defining the urinary microbiome. So it's a living microbial community with its collective genetic and the metabolic ecosystem that's within the urinary tract. It's not merely pathogens, but rather a complex host microbiome interplay, and it's only detected with advanced culture techniques. So we said it includes bacteria, your viruses, fungi, and also eukaryotes. It's distinct from our gut and vaginal microbiomes. However, they all interplay on each other. We know it's more diverse in females than in males. And the most common genera that we know about in the urinary microbiome is your Lactobacillus, Corynebacterium, Gardnerella, Streptococcus, and your Escherichia families. So detection techniques, how do we assess for the urinary microbiome? So the picture there kind of explains all the different culture methods. I'll just run through it, the pros and cons. By the standard way, it's the cheapest, it's fast, but it misses most of the fastidious organisms. Where your enhanced quantitative urinary culture techniques, they're more sensitive, they're very labor intensive. It's the second from the left on the picture. If you look at all the steps, all the things that need to be done to actually culture it. And then we have our 16S, your RNA, which is your next generation sequencing. That's highly sensitive, however, it cannot determine viability of these bacteria. And then your metagenomics, which is the most comprehensive, but also very effective, expensive. Right, so what influences our urinary microbiome or the urobiome? So firstly, we know age. So in our young patients, we know there's less or lower bacterial diversity. Then when you become a young adult, it's relatively stable. And then as you get to the older side of things, then you see an increase in the microbial diversity. With sex, With females, they have a shorter urethra. It's in closer proximity to your vaginal and your gastrointestinal microbiota, so there's a greater influence from your vaginal periurethral flora, whereas in males with a longer urethra, antimicrobial properties of your prostatic secretions, there's lower rates of ascending infections. Hormonal status. So we know estrogen promotes lactobacillus dominance in our urine, and you can see that with postmenopausal women, where the amount of lactobacillus dropping or the dominance of it dropping. Antibiotic exposures, it influences our urinary microbiome by reducing the diversity. It can also help lead to the overgrowth of more resistant strains, and it will create, in essence, in long-term, a dysbiosis. Catheters, they disrupt our normal urothelial defense mechanisms. There's an opportunity for to create biofilm surfaces and for microbial adhesions. Diabetes, glycosuria, favorable in conditions to promote growth of certain bacteria. Immune status, we know with immunosuppression, it allows for colonization by atypical organism usually of low virulence, and then your pelvic floor function affects it with incomplete bladder emptying, leads to urinary stasis, and it also then favors your microbial persistence in there. So bacteria, the question now is it our friend or is it our foe? Is it beneficial, is it not? Where are we going? So just if we look at the urobiome and specifically to urological conditions, what has been found, what's not, where are we going? If we look at studies looking at overactive bladder syndrome or overactive bladder, we know that the urothelium and the suburothelium, it plays an important role in the pathophysiology. The studies are currently being done trying to correlate between the symptoms and the microbiome in these patients with overactive bladder. And looking at it, the study that I've put here, the picture of the study that I put here, that was a case-controlled study where they examined the microbiome in patients with overactive bladder and compared it with healthy controls. If I remember correct, I think it was 60 patients with overactive bladder, and about 30 of them were used as controls. And they looked at the midstream urine samples and enhanced culture techniques, and they found in the subgroup or the patients with overactive bladder symptoms, they definitely showed a decrease in lactobacillus compared to the control group and increase in proteus species. Relevance of that have not completely been established. These are some other studies that have been published now in the last couple of years, and all of them try and look to see if there's certain microbial patterns or microbiome patterns that can be linked to certain symptoms, specific symptoms of your lower urinary tract symptoms. If you have a look at that, what you'll see is this relatively different findings in between this, most of the studies. However, the one bacteria that keeps on, or the species or genera that keeps on popping up, is lactobacillus. So there's probably going to come some new research showing quite significant impact due to that. This paper looked at urobiome changes in overactive bladder patients with treatment in adult females. And actually what they found was that when they looked at the pre-treatment urobiome characteristics, there were certain characteristics that were associated with treatment response, specifically with regards to solifenacin, but not with mirabegron, which is quite interesting. And then they also found afterwards, after being treated, that there were differences in the urobiomes and how they changed with treatment of both of these drugs. So if we look at the urobiome and what we know in interstitial cystitis or bladder pain syndrome, so we know the key findings from most of these studies are showing that there's an altered diversity in your urinary microbiome. The findings are inconsistent in between them, and numerous studies, once again, they report on the dominance of lactobacilli in the urine of these patients with interstitial cystitis. However, we are not yet sure why this is a dominance, if the lactobacilli is a promoter of the inflammation, or if it's a compensatory response, or if it's maybe just even a marker of dysbiosis. Then the next thing they looked at was if there was differences between the composition in the Hanna-Lesion interstitial cystitis and non-Hanna-Lesion interstitial cystitis. Just for those strong academics, I know the nomenclature has changed. It's just in the studies they were still referring to it as is, so that's why I kept it like this. But like I said before, dysbiosis and altered diversity, that's probably the two main things that we know that's amplifying under local and systemic inflammatory responses in these patients. And if we look at the urobiome in LUTs, or it's still with prostatitis and BPH, newer studies are showing there are some emerging associations with it. We know that the gut microbiome can influence our lower urinary tract symptoms by modulating our systemic inflammation, your immune function, and the metabolic processes, and then all impacts your BPH progression. So what we're seeing now is that the urinary microbiome might influence this via localized inflammation of the immune system and interactions with microbial metabolites. And this, I think, is exciting, not just because it's as an etiological factor in BPH, but there's also something that can possibly be used for prevention and treatment principles going forward. Then, yeah, the reason why everyone's here today for recurrent UTIs. I'm going to touch on it, say what it is, and then obviously Dr. Chetty will give a brilliant talk right now explaining all about this and hopefully simplify everything. So what we see in the urinary microbiome with these patients with recurrent UTIs is that there's a shift towards uropathogenic species. The dysbiosis might actually predispose patients to recurrent UTIs. The question of persistent reservoirs in the urothelium, and that's got to do with UPEC and your intracellular bacterial communities, which will all be covered in the next talk. And then that long-term antibiotics might actually worsen this dysbiosis and predispose our patients to getting these infections again and again. And then we know that, or we've seen now that vaginal estrogen and probiotics might actually show benefit. I'll touch it here and I'll touch it again. I'll say it, but I think important with UTIs and stuff for us to just, again, how can I say, put emphasis on is not to treat asymptomatic bacteria, as we actually might worsen the problem going forward. So this picture, it shows how the risk factors or the recurrent UTIs are the interplay between the different microbiomes and how they alter in the urinary microbiota. So like we said, with increasing age, there's a drop in your estrogen levels. With the drop in your estrogen levels, there's less lactobacilli, and it allows for your pathogenic bacteria to proliferate and go on. And it's the same with your gut. If the gut bacteria have more pathological bacteria, it affects the urinary system. So the literature, what we know and stuff, this is was a urinary tract microbiome. They tried to exhibit to see where the host and genetics and environmental, how they all influence each other. And it was done in the UK, part of a bigger twin study where they looked at 1,600 twins and they took the urine samples and they tried to estimate, like I said, the contribution of the genetic and environmental factors in the microbiome variation. And basically what they found was that the most important things in determining your microbiome was age, menopausal status, if they had prior urinary tract infections, and then the host genetics. Those were the top factors that were defining the urinary microbiome when they looked at in terms of microbial diversity, and with age being one of the big kickers. So this study, I'm quoting here with recurrent urinary tract infections. This was a controlled cohort study. It was only 75 women, and they put them in 3 cohorts. The first cohort was if they had no history of prior UTIs. The second one, if they have a history of recurrent UTIs, and then the third group was if they have symptoms currently of an active UTI. They collected clean catch sample urine specimens all over these patients, and then they did shotgun whole genome metagenomic sequencing on these patients. What they found was that in women with recurrent UTIs history, even when they were asymptomatic, their urinary microbiome showed enriched with pathogenic species, and it actually had fewer beneficial bacteria when comparing it to those patients who did not have a history of UTIs previously. With hormonal associations, they found that those patients that were on estrogen hormone therapy, was localized and systemic, they exhibited increase in the prevalence of lactobacilli and other favorable bacteria, and that there was also a strong correlation between the bifidobacterium and the lactobacillus abundance with urinary estrogen metabolites when they compared that or observed that among the women without UTI histories. And then another thing was they looked at functional gene signatures, and they detected there was distinct antimicrobial resistant genes profiles that were identified in these women who were having a history of recurrent UTIs, showing with enhanced or enriched antibiotic resistant gene content, regardless of their current infection status. So clinical implications, I think first thing is probably our interpretation or the way we view culture results that needs to change. And that we need to realize that some microbes and bacteria might be protective. And again, now that comes with treating asymptomatic bacteria, where I think we're treating and over-treating of UTIs, we are creating this scenario with the dysbiosis, and decreasing the biodiversity and creating an environment for future problems. So yeah, I think the concept is rather not to think of to restore the balance versus actually sterilizing the patient. Therapeutic frontiers, where we're going, what's new. So probiotics, vaginal estrogen, it's been established that there are some benefits to it. But now, which I found quite interesting, we'll talk a little bit about it, is fecal microbiota transplants. It's associated with good results, and then also phage therapy. However, all of these are still under study, and there's no real conclusive evidence yet. So two studies I'd like to show here. There's one there on the left. It's the fecal microbiota transplant was associated with the resolution of recurrent urinary tract infections. So what they aim to do, and I think it was in China, if I can remember correctly, was basically they prospectively accrued a database of patients who underwent fecal microbiota transplants for recurrent C. diff infections. And then they retrospectively looked at these patients' data to see if any of them had recurrent UTIs in the 2 years prior to the microbiota transplants. And they identified, I think it was 11 patients who had that. And then they followed them up prospectively going forward. And what they actually found was that in the 11 patients that had the recurrent UTIs prior to the transplant, none of them had recurrent UTIs post-transplant of it. And I think mean time to your first UTI was 19 months after it. So there's definitely showing or strengthening the hypothesis that the gut microbiome also affects our urinary microbiome. But bigger numbers will be needed to prove all of this. Then phage therapy for urinary tract infections.
Just a morning meeting.
Right. Cool. It's a promising alternative to antibiotics for managing UTIs, especially now in the phase where we go with polymicrobial resistance. However, the studies that's been published has been small numbers. It's not consistent. No big real randomized control trial, so we don't really yet know how effective this phage therapy might be going forward. So this I found quite interesting, and this will probably be play a big influence later in the future, but urinary microbiome and bladder cancer. So we know cancer development and progression, it's a interplay that's usually between your normal and tumor cells with the extracellular environment, and that bacterial products, they can control the tissue homeostasis and inflammation. So in theory, this long-term dysregulation that's caused by dysbiosis can create a pro-tumorigenic environment. Evidence is still emerging. There are definitely differences that's been detected. Everything is still investigational, but I definitely think there's potential future use in diagnosis and treatment prediction. So a couple of studies that I put on here, which I just looked at of the urinary microbiomes in patients with non-muscle invasive bladder carcinoma. The study on the left, they looked at the microbiome. They looked at 31 patients with urothelial cell carcinoma of the bladder and would compare that with 18 healthy controls. And they found that in the patients with urothelial cell CA, there was a much higher abundance of Acinetobacter, Anaerococcus, and Sphingobacterium families compared to the controls. However, they couldn't establish a clear relationship between it. On the right, they compared also the urinary microbiome of patients, or let's say all of them looked at males with urothelial cell CA of the bladder. But the study on the right, they compared 12 patients with bladder urothelial cell CA with 11 controls. they found again that the overall microbial diversity and microbiome composition was not significantly different actually between the two groups. However, they reported that they could identify operational taxonomic units that was more abundant in either group. And amongst those that they saw in the bladder cancer group, the bacteria or the operational taxonomic unit that they identified was a fusobacterium, which we know can play a role in colorectal CA, but no link has really been established in bladder. However, this could be a possible pro-tumorigenic pathogen, but the cause-effect relationship still needs to be established. Yeah, then on the Journal of Microbiology, there was a study which also looked at the urinary microbiome from 29 patients with urothelial cell CA compared with 26 of non-cancer patients. And they also actually again found higher abundance of Actinomyces europaea species in these patients with bladder cancer. So it seems like the Actinomyces family species might actually be an indicator for this disease. Then here on the right-hand side, and this was quite interesting, and this was, I think, published earlier this year, if I'm correct now, but they looked at the urinary microbiome changes in non-muscle invasive bladder carcinoma patients during BCG therapy, and then comparing them the BCG responders versus non-responders to see if there's any correlation and anything we can take from it. So they looked at, they used males who was recently diagnosed now with the urothelial cell CA of the bladder. They were post resection. They had a history of prior bladder cancers. They could not have any active UTIs or history of UTIs, and they could not have taken antibiotics in the prior 20 days. Yeah, then they looked at the urine prior to induction and then weekly after, and to see if there were any big changes. So the first big thing that they realized with BCG was that after your first week of induction, there's a significant drop in the biodiversity noted. And that there were differences in the microbiome compositions between the responders and the non-responders. With non-responders, they said exhibited, I think it was 12 to 13 times higher abundance of a genus Oryspira, and that they had a lower, 27 times lower of Negativococcus succinivorans. And that these, even the higher abundance of the genus of the Oryspira with BCG, it did came down to the end, and it was actually again an 8-fold decrease. So it looks like there are things that can point us potentially in directions of who might respond, who might not respond. But we need much bigger studies to prove that. I think total patients in this study again was only 10 or 11. So what does the EAU, AAU, and Campbell say about the urinary microbiome? I think our major bodies, they're recognizing the importance of the urinary microbiome, that it's rapidly advancing. There's no formal guidelines yet. In the Campbell's, there's about, I think it's a small 2-3 paragraph section on it, not really much yet. Future directions, where do I see us going, or what I think is going to happen? I think we're probably going to move into a microbiome-based diagnostics era where patients will be treated individually differently based on their biome picture. And this will probably also find its way integrate into our antibiotic stewardship programs. So to take home today, I think very important is to know that urine is not sterile. That's very important. And that the microbiome of the urinary tract, it impacts our overall urological health. We should consider the microbiome and recurrent lower urinary tract symptoms and infections, and that restoration might be better than eradication. And again, not to treat asymptomatic bacteria. And then, yeah, to conclude, I went on quite a journey when reading all about this. And I think we know a lot now. We know a lot more than what we've ever known, but I don't think we know yet. And I think we're still going to probably find out a lot going forward. For now, I haven't come across anything that's really going to change our current practice of medicine. Yeah, thank you. I'll get this open again.
Thank you very much, Erki, for your excellent talk. Like you mentioned at the beginning, we aren't a microbiologist, but you've explained that so nicely that I think we'll have a much better understanding of the concept of the urinary microbiome and its importance. Any questions from the floor? Maybe while I think of something to ask, I mean, most practices still use the sort of gentamicin if you're going to do a sort of procedure, even if a patient has a negative culture. Pre-op, if you're going to do an invasive procedure involving the urinary tract, you normally cover with an aminoglycoside because of the gram negatives and gram positives. Do you think that should still be sort of standard practice? You do mention, obviously, we don't want to eradicate, but we know that it's not as simple as just everyone having an E. coli, if anything.
Yeah,
We sort of move towards augmentin now just because it's a bit of a broader cover. But what are your thoughts on that?
yeah, Dr. Appel, I must say this is now purely my thoughts. I didn't specifically read anything about this. And I think it's probably always going to have to weigh the risk versus benefits in these patients. And I think you're going to struggle to convince me not to give a prophylactic antibiotic prior to surgical incision. But maybe that might change if more research comes out and it shows. But for me, currently, I think the risk of systemic sepsis still outweighs not treating it in the current pre-op situation.
Yeah, agreed. Yeah.
Yeah.
And then just out of interest, that one article you spoke about, and I think it was the overactive bladder patients that after being treated with beta-3 agonists and potentially sort of antimuscarinics, there was a change in their urinary biome. Is that sort of was that just sort of blood activity changing sort of the environment, or do those things sort of have an indirect,
Yeah,
minor antibiotic effect?
Yeah, so it's strange because I mean neither of them I think would alter your bacterial communities, and it's not, how can I say, specific bacteria that they found different, but it's more if you look at patterns of bacteria and the formations of the colonies that would change after the treatment. So why and how, I'm not exactly sure. That's just an observation. And it was for me quite interesting that they could, in some of these patients, based on their pre-treatment biomes, see that they would not respond to sulfonylurea, but rather just respond to mirabegron. So that's potentially something that can help us a lot with these difficult to manage patients.
Very interesting. Thank you, Erki.
Yeah, cool. Thank you.
Any other?
Who would you recommend you to asymptomatic bacteria?
Dr. Wellman just asked, so who would you treat for asymptomatic bacteriuria? So obviously we know it's obviously pregnant patients.
Yeah.
Who would you treat?
So as far as I have it with the guidelines, we are only treating pregnant patients with asymptomatic bacteria and patients that are undergoing invasive urological procedures where we're going to breach the mucosa. Other than that, it's not the cardiac patients, pacemakers, orthopedics we don't treat anymore.
Yeah, agreed. I don't think that's likely to change anytime soon.
Yeah.
Good. Okay. Thank you, Mark. Thank you again, Erki, for your talk.
Great.
If you
You're
could just
welcome.
hang around maybe online in case somebody does have a question from the audience.
Okay, that's cool. I'll stay.
But yeah, thank you very much, Erki. Really appreciate it.
Awesome.
Is our next speaker available?
Hi, I'm available. Sorry, I'll just try and do the screen sharing thing. I'll just.
I don't know if Erki needs to stop sharing, maybe.
Maybe just a comment while we wait. Yeah, there was a study done on asymptomatic bacteria and orthopedics implants, and they actually found that although they do have decreased sepsis of the metal implant in terms of what they could culture with asymptomatic patients with UTIs, the long-term complication was no different. And what they sort of found is that it's actually more the patient's profile. The specific patients are just high risk of actually having sepsis needing a removal of the implant.
Thank you very much, Mayor.
Are you able to see my screen share?
We are indeed. Thank you very much. You can just make it full screen.